This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard of Cardiology Specialists of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Well, welcome to our podcast on cryptogenic stroke and PFO, to close or not to close, and the role of the heart-brain team. For us today, we have a very, very special guest. We have Dr. Kwon, neurology and assistant professor at the University of Alabama in Birmingham. We have Dr. Ekaterina Bakradze, Eka, also assistant professor of neurology at University of Alabama. And finally, with our co-host today, Dr. Mustafa Ahmed, Director of Cardiovascular Services, Interventional and Structural Program, also at the University of Alabama. So welcome aboard.
Thanks, Dr. Bouchard. So, this is one of the podcasts I've most ever been excited about doing. And the reason is, I just think this is going to be tremendously helpful for patients that have been told, you have a hole in your heart called a PFO, and you may or may not need this closing. And, I've been in the structural heart field for around 10 to 15 years now, and really seen the evolution of this and feel so much better at this point in time in my career about the way these things are approached. And the reason is because of the guests, the experts that we have on with us today, who are, Dr. Bakradze, Dr. Kwon, specialist stroke neurologists. And 10, 15 years ago, I tell you, these things, when you were told you had a hole in your heart, it was like, let's close it. And so someone would send it along, and the interventional cardiologist would be like, oh, great, I'm going to put a wire across this thing and put a device and close this thing, and suddenly all this good's going to be done. And thankfully, that got questioned. And then there was this whole period where we were like, gosh, maybe we shouldn't close any of those, or maybe we should close much less. And that led to this period of really feeling like, gosh, are we not helping some people that need helping? And are we helping some people that need helping? And then these trials happened. And then what we realized, like the rest of heart disease, maybe, and I'm sure a lot in neurology, is really what we need to do is get a team together. And so the role of the interventional cardiologist, which is myself, has now been relegated appropriately to say, we're going to look at some cardiac causes, and I'm going to look at that hole and see if it can need closing or not. But as with the rest of medicine, I want to really know, before we do that, are we helping someone? And this team approach has allowed us to say, as a team, we feel we're doing a thorough investigation. We're getting all the experts needed. And when we close it, we really feel good about that. And when a patient comes to see me, the idea in their head often, because they're sent by cardiologists and maybe other neurologists and maybe non-specialists, to say, gosh, you've had a stroke, which is terribly scary, and you need this thing closing. And the first thing I tell patients that come to me is, that's great, and you have this hole in your heart, but now I'm going to hand you over to the rest of the team. And this team approach is known as the heart-brain approach. And it really comes down to that. If the heart-brain team think you need closing, we're going to close it. And if the heart-brain team think this would be more risky and potentially harmful over time, then we'd never want to do a procedure on someone that isn't going to help. And hopefully by the time this podcast is finished, people will understand why we do this approach, why it's such a thoughtful approach, and why this is the future of, in my opinion, any PFO that's ever going to be closed should go through this approach.
Well, thank you very much, Mustafa. And just to put things in perspective, we know that stroke is the fifth most common cause of death and the leading cause of preventable adult disability. Stroke costs about $34 billion every year. Every year, about 800,000 people have a stroke, and almost 90% are ischemic, meaning that the blood flow of the brain is blocked, the so-called brain infarction. Nearly 1 of 4 are in people who've had a previous stroke. And every year, over 200,000 ischemic strokes are considered to be cryptogenic. And of these, 50% almost have a PFO or patent foramen ovale. So let's go on. Dr. Bakradze, maybe Eka, we could start with you. We have a lot of definition, to go through. But first, what is a cryptogenic stroke?
Yes, well, thank you so much for having me here today and for this really important and interesting topic and area of my interest. So I agree, there are a lot of definitions here that we have to clarify in order to continue talking about the PFO and stroke. To give you a just sort of general overview, the cryptogenic stroke is defined as a brain infarction that is not attributed to other known etiology. For example, large vessel disease, small vessel disease, other known cardiac etiologies for stroke, such as atrial fibrillation, and is usually determined after extensive vascular, cardiac, and blood work evaluation. What it really means is that I'll sort of try to give you more detailed overview now is that we like to categorize stroke. We like to classify strokes into different etiologies. And the reason we do that, the stroke neurologist, is that it allows us to do then patient-centered appropriate workup and then tailor the management based on the etiology. There are several stroke etiologies nowadays, but the most commonly used in clinical practice as well as in research is called TOAST classification. Not like a tea and toast, the TOAST classification. And that divides strokes into 5 different categories. The first and one of the most common etiology for stroke is cardioembolic. And all of you would know what that means. AFib being one of the most common cause of cardioembolic stroke etiology, other valvular heart diseases, depressed ejection fraction, all the cardiac etiologies go into this umbrella and is one of the most common cause of stroke in the Western world. There is second stroke etiology called the large vessel disease, which really means that the stroke was caused by a culprit vessel stenosis or narrowing more than 50%. The narrowing of the vessel can be in the neck, in the brain, and there is also something called small vessel disease, that is a third etiology, and these are usually strokes that happen in the very specific areas of the brain and are usually due to disease of the small blood vessels, and things like high blood pressure, diabetes are usually the culprit etiologies for this type of stroke. The fourth is a very small subset called other known etiologies, and here we include things like dissection, which is a tear of the blood vessel wall, moya, it's usually a small subset. And the last fifth, pretty large stroke etiological category is cryptogenic stroke, which really means that we do not know the cause after extensive diagnostic evaluation. The term of cryptogenic stroke and concept has evolved. Before we would say cryptogenic also if you had 2 competing mechanisms, or if you had just incomplete workup, we would also call this cryptogenic stroke. But nowadays, when we talk about PFO and cryptogenic stroke, what we truly mean about cryptogenic stroke is embolic stroke of undetermined source, which really means that it's a stroke that is embolic, affecting the certain areas of the brain. And we did not find any etiology after extensive diagnostic evaluation.
Su Young, how frequently do you see cryptogenic stroke in your practice?
Yes, even after a thorough evaluation at UAB and at other centers nationally, the rate of cryptogenic stroke is about 30%, up to 30% of all strokes are categorized as cryptogenic.
Thank you, Sue. Let's go and continue with the definition. And this time, Mustafa, maybe you could explain to us, what is a PFO or patent foramen ovale? It's just a little hole in the heart, or what is that?
Yeah, so PFO, a hole in the heart, it's interesting, right? There's several of us on this podcast at the moment. And what I tell the patients that come in with stroke is, even if they come in with 3 family members, I'll tell them 1 in 4 of us around that was born with this thing. Even if none of us had had a stroke in this room, 1 in 4 of us was born with this thing. And let's just say you have to have had a PFO to be essentially alive at one point, because when you're in your mother's stomach and blood is flowing in, you don't breathe oxygen, right? You're in this fluid. And so that hole between the left and the right side of the heart, that is required to get the blood needed with the oxygen needed to go and allow the baby to kind of flourish and survive before it gets born and takes the first breath. And so that hole is there. It's just that in about 3 in 4 people, that closes off naturally once after birth. It closes off due to a variety of factors, including raising of the pressures inside the lungs and other pressures with localized, really kind of getting down to a molecular detailed expression of hormones and that promote closure of this thing. But in 1 in 4 people, that stays there. And the important thing to realize at this point is the overwhelming majority of people with a PFO are never going to have a stroke. They're never going to need it closed. And when you walk around, if you have a PFO and you haven't had a stroke, until one day someone tells us otherwise, this is considered almost a normal variant. It just happens that hole, when as you kind of get older and you have, different things change in your body's physiology, blood can get across that hole. And the thing that causes strokes, the kind of embolic stroke that word was used by Dr. Bakradze earlier. Really what that means is a little bit of tissue or a little bit of blood clot or something has kind of flown through the circulation and jumped up and stuck in the brain. And when it sticks in the brain like that, until it goes away, that brain tissue starts to die. And one of the ways of the clot getting into the main circulation of the body, because on the right side of the system, known as the veins, everyone's heard of clots in the veins. These things form probably more commonly than we know. Really, the role of a PFO is to say this little clot has gone in the veins, and if you didn't have a PFO, that'd just go to your lungs, and you would never know it most of the time. But what happens in the PFO is that goes in and sneaks across that hole due to various different factors. We'll talk about some of those factors in a while, but then gets into the left side of the heart. The problem with the left side of the heart is that is what supplies the blood to your brain and to your organs. So that clot's now on the left, and when the heart beats, by unfortunate circumstance, when it beats, that clot will shoot up into the brain and lead to a stroke. And so when we say, that PFO may have been related, really what we're saying is that hole in the heart was likely to have been, all these other things are going to get ruled out, and that hole in the heart's likely to have been associated with a little piece of blood clot flying across it and going up to the brain, which is why we would want to close it.
Thank you. So let's say, Sue Young, we have this young woman that is coming with a stroke. So explain to us a little bit, what is the heart-brain approach, to work up a patient like this, or, from admission to diagnostic testing and so forth?
Mm-hmm. With any stroke patient, the stroke evaluation, the main purpose of the stroke evaluation is to find the cause of the stroke and trying to put that stroke into one of those categories that Dr. Bakradze explained so that we can treat and prevent future strokes from happening. And so when we encounter a stroke patient, some of the stroke workup that we do includes looking at the heart, looking at the blood vessels going from the heart through the aorta, through the big major arteries in the neck into the brain, looking at risk factors that can cause blood vessel disease or small vessel disease, looking at various lab results, and really looking at the patient, the whole patient, to find out the cause of the stroke. So specifically, to look at the heart, we start with an EKG to see if there's any abnormal rhythm that might be cause of the stroke. We usually monitor them with telemetry monitoring and oftentimes with some prolonged heart monitor device. And we get an echocardiogram to look at the structure of the heart. And when a PFO is suspected, or in any embolic stroke, actually, we generally get a bubble study to identify if a PFO is present or not. And in certain patients who need more detailed workup, we might get a TEE or further cardiac imaging. And then to look at blood vessels, we get CT angiogram or MR angiogram, carotid ultrasound, or in some cases, catheter angiography to look at the structure of the blood vessels. Brain MRI is an important part of the stroke evaluation to look at the location and size of the stroke. And depending on the characteristic of stroke, that gives us a lot of clues as to what was the cause of the stroke. Usually embolic strokes have a certain location and appearance, whereas strokes due to small vessel disease have a different appearance. And then we look at laboratory workup to assess the risk factors like diabetes markers, cholesterol markers, clotting factors like hypercoagulability panels, et cetera, et cetera. So that's the basic workup for pretty much any stroke patient. And then depending on what we find on some of those basic workup, we may do even more detailed workup.
Good. Mustafa, can you go a little bit into more detail about how do you make a diagnosis of a PFO, and do all PFO look alike? I mean, are there some that have maybe kind of a characteristic that are more likely to, be involved in a stroke?
So if you're okay with it, I'm going to slightly broaden that question. And I'm gonna talk about the cardiologist role in the workup of this, because as we just learned, there's so many things that can cause a stroke and so many things to look at. As a heart doctor, what is it that I'm looking at when someone comes with a stroke? And these guys are probably going to add more to this and say, actually, I would add this, this, and this. But one of the first things I look at is, particularly is for an irregular heartbeat. And so for that irregular heartbeat called atrial fibrillation, which is a common cause of stroke, we will look at a baseline heart tracing. I'll look at any other evidence. When the patient was in hospital, did they have a heart tracing? Have they had a history of regular heartbeats? And ultimately, I'll put at least a 30-day monitor on that patient because, again, this is a much more common cause of stroke than a PFO. And so really what we want to do is rule out an irregular heartbeat. And some patients will have a loop recorder, which is a longer version of that monitor put in, and that's just a little implantable under the skin. But really what we're trying to say here is we really want to make sure you don't have AFib. Now, there will, and I'll let these guys comment in a while, there may be situations where even if someone did have AFib, if they had a PFO and obvious evidence, that we would still close it. But we still want to make sure we're doing that because that's a treatable risk factor over time, which we want to know about and treat. So that's the heart rhythm. The next is structure of the vessels. So we may get an ultrasound of the carotid arteries, and the MRI scan may be done later and this may be superfluous, but we want to know that you haven't got a blockage or obvious plaque or a sign of damage in either the aorta that's coming off the heart or the vessels, basically everything just before the brain vessels. We want to make sure there's no obvious vascular anomaly that could have led to that stroke. And so then I'd come to the PFO. Actually, there is one other thing. I also would want to know that that patient didn't have any issues with their valves in the heart, whether that's the mitral or the aortic valve. And that could include some small growths, a history of infection, or other history of abnormalities on those valves. And so that's why the baseline echo, every patient that comes in will get all the tests we just talked about from a cardiologist standpoint. So then we come to the PFO. Now, as we said, most people that have a PFO don't have a stroke. But what we've learned over time is there are some features to that PFO, that hole in the heart, that are associated with the group that's going to have stroke. I don't think we're 100% there yet to say we definitely know these things are associated with stroke or not. There may be some small holes that are associated with stroke, and there may be some large high risk factor ones that aren't. But I will tell you, the approach we take now is a lot more refined than the approach that used to be taken, 20 years ago. And so really think of the PFO as a tunnel that never closed. And that tunnel is the escape route through which these molecules and particles of blood go to cause a stroke. And so a long tunnel, a really wide tunnel, this bubble study that was talked about before, really all we're doing is injecting a bunch of bubbles into the vein, which is agitated, is shaken up saline, and we put that in, it has the appearance of bubbles. And there's this moment in people with a PFO that when you inject, these bubbles will just fly across to the left side of the heart. And really, we look at that as saying, gosh, this clot then could fly across to that side of the heart. So really, we're looking at tunnel size, tunnel width, the features of the tunnel that make it particularly mobile. And the reason that mobility is important is that when we take deep breaths in, pressures on one side go higher, and they tend to move that tunnel to the other side, increasing the width and size of that thing and facilitating blood or whatever material to go across there. So those are the features. So anatomic features of the PFO, and I'm sure these guys will kind of go into a bit more detail in that. There's some more nuanced testing that can be done in the brain that can also look at whether a PFO is significant or not.
Are there certain clinical characteristic that maybe makes you think more of a cryptogenic stroke? I mean, of course, you're dealing with a younger patient, a lot of times. We're talking between 18 and 60, right? But are there certain features that make you think more of a cryptogenic stroke or something that is maybe could be associated with a PFO?
Yes. So as Dr. Ahmed and Dr. Kwon mentioned earlier, about 25% of the population do have a PFO, and not all of them develop stroke. So the bigger question that we ask is PFO that we found during stroke workup, is that incidental finding? Is it basically a smoking gun or guilty by association? So we spent quite a deal of time really looking at the stroke features as well as the PFO features and trying to see if there's any correlation. So cryptogenic stroke itself, and as we clarified it, embolic stroke of undetermined source that we really refer here when we say cryptogenic stroke, means that the stroke must be embolic. What that means is that the stroke, the infarction or the brain damage, how people like to call it, is in more sort of superficial, higher parts of the brain called cortex, as opposed to more deeper structures, and they're called embolic strokes. There also tend to be multifocal, not affecting just one single area of the brain, but affecting multiple areas of the brain. That is also a characteristic factor that there was a clot somewhere that went to the brain. And again, ruling out all the other large vessel disease or other certain tearing of the vessel wall and other hypercoagulable condition, and Dr. Kwon mentioned. And as Dr. Ahmed was saying, we also look at the PFO characteristics and try to see if the PFO features are the ones associated with stroke. Not every PFO causes stroke, right? Or is associated with a stroke, to clarify. The PFOs that cause large shunts are more likely to be associated with stroke, as Dr. Ahmed was saying about the bubbles crossing from the right to the left heart. More bubbles are crossing and you're finding on the left heart, larger is the shunt. So, usually shunts where you see 25 or more bubbles are more likely to be associated with stroke, as opposed to really small shunts that cause 5 or less bubbles. As Dr. Ahmed also mentioned, the hypermobile, areas of the septum of the heart, they're called atrial septal aneurysms, in association with PFO are more likely, to be associated with stroke as opposed to PFO alone. But in terms of the stroke itself, is really just the location of the stroke being embolic, being superficial, cortical, and being multifocal. And as Dr. Kwon mentioned, again, the culprit and the most important thing is to do really thorough evaluation and really determine that you have ruled out the common stroke etiologies. And we might talk about this later on, but there's something, we use different algorithms, the clinical algorithms which help us to determine this association between PFO and the stroke, and including patient's age, lack of traditional vascular risk factors, the size of the shunts, the smoking status or not, location of the stroke. We actually come up with an algorithm. We call it a rope score that helps us determine if the PFO that we found during index stroke, is this incidental or is associated with stroke. So something called the concept of the rope score. Usually if you have rope score 7 or higher, more likely that the PFO that you found during workup is likely associated with stroke, as opposed to rope score 7 or less. And there's something called relatively new concept I would like to mention called Pascal algorithm that really has been talked during last 2 years or so, is even more sort of very flexible clinical practice approach that, including rope score, including more detailed PFO characteristics, helps you determine if, what is the probability of the PFO association with the stroke, and really divides unlikely, likely, highly possible, probable, likelihood that the PFO is associated with stroke. So we use these algorithms, the rope score and the relatively new Pascal algorithm, on daily practice when we try to determine if this PFO is, again, smoking gun or just incidental finding.
What about some of the non-invasive evaluation, Sue, like the transcranial Doppler? Are you still using that?
Yes, we do have the ability to do transcranial Doppler, or TCD, and especially TCD with bubble study, which is the most helpful when a PFO is suspected. So what that actually does is we put an ultrasound probe on usually one of the middle cerebral arteries or arteries of interest, and we keep that ultrasound probe on that artery, and then we inject agitated saline, or saline with some microbubbles in there, into the vein, and then wait to see if those bubbles actually reach the brain. And if there is no PFO, if there's no hole in the heart or no communication between the right and left side of the heart, then the bubbles should all end up in the lung, get absorbed in the lung, never reach the brain. If there is a PFO, or communication between the right and left side of the heart, those microbubbles will cross through that PFO and reach the brain circulation, and we'll be able to pick that up with the ultrasound probe, and we'll hear those bubbles reaching the ultrasound probe. And so after the TCD with bubble study, we're able to categorize, depending on how many microbubbles reach the ultrasound probe. If it's a very small proportion, if it's 1 or 2 bubbles reaching ultimately the brain circulation, that would be categorized as a small shunt. And if we see a lot of bubbles reaching the brain circulation, that would be a large shunt. And sometimes we have a curtain effect where we see a huge amount of bubbles reaching the brain circulation, too much to count. And that would be called a curtain, or a very large shunt. And that gives us additional clinical information to the information that we would get from a echocardiogram. And the echocardiogram will be able to look at the PFO, and the TCD is really assessing whether these bubbles actually reach the brain circulation. Is this clinically relevant in a stroke?
Seems pretty specific, going to your head. It's got to go to your brain. So we have this young woman, she's had a stroke, and obviously we're talking about medical therapy versus, treatment of the PFO. As part of our background, still, what is our medical treatment for, these young patients coming with a stroke?
So depending on the workup that we do, if we don't identify any known cardiac problem, such as atrial fibrillation or valvular problem, if all of that is ruled out, and we rule out plaque on the arteries, any thrombus sitting in the arteries, and we've ruled out the traditional risk factors that lead to stroke, and especially small vessel disease like hypertension, diabetes, cholesterol issues, smoking issues, if those are all felt to be less likely or not contributing to the stroke, then really the default for a cryptogenic stroke would be an antiplatelet agent, something like an aspirin. That would be the most accessible, or in some cases Plavix or Agrinox or things like that. But an aspirin would be sort of the default antiplatelet agent that we use.
as our mainstay for medical treatment. So again, maybe Mustafa, we could kind of discuss a little bit as part of our background, what is the way to really treat a PFO? What kind of, how do we do this? And then we could talk maybe a little bit more about what have the clinical trials, taught us.
A really important takeaway from this, and we know this from dealing with heart attacks, is when someone comes in with a blockage and a heart attack, and I mean, Dr. Bouchard, you're the best at this. I mean, I worked with you for a long time, but really we double down, right? Our conversation is, let's talk about risk factors. Because we talk about putting a stent in people, but really all of us know we can or cannot do that, but high blood pressure, diabetes, cholesterol, activity, lifestyle, don't smoke. I mean, the list just goes on and on and on. And with stroke, the same thing is so important. When you've had a stroke, that's the primary event. Really, everything we're doing from that point on is called a secondary prevention measure. And just as important as this conversation about PFO is, double the importance of all the other stuff. And that becomes germane to the discussion with the patient of, should we close this thing or not? Because what we tell people is, well, and I tell you this as someone that everyone gets sent to me has the expectation of having the PFO closed. And so then they go back through the pathway, and we'll discuss this a bit later, but some will get closed and some won't. But the people that what I tell people is, well, if I close your PFO and we don't take care of any of those other things, you realize we've just put a device in you which has its own natural history. There's a very, very tiny, I worry less as someone that does a lot of these. I worry less about the complication. But you never would want to do a procedure in someone where you're going in their heart without acknowledging there's a small chance of a complication. But then everything we introduce into someone's body may have a risk of complication over time, which is why we want a very, very good reason that we're going in. And no matter how good the safety profile, no matter how fast and quick and efficiently and safe we can do the procedure, we want to know it really needs doing. And so if an aspirin and a statin and maybe sometimes a more powerful blood thinning agent has been shown and proven to reduce your risk by a magnitude greater than that of closing the hole, it's really difficult to justify doing that. And one of the questions I've got for these guys after is, and I get this in clinics, I'm asking this genuinely, I get asked the question, well, that's great. Why don't you take that risk factor off the table anyway? Why can't you just come in and close that PFO? Why not? Yes, we're going to take the blood thinner. Yes, we're going to take. And then the other question I get off patients is, I don't want to take blood thinner. I don't want to take aspirin. I don't want to take Plavix. I don't want to take Coumadin. They don't want to do this whole new blood thinner. And they're like, can I not just have the hole closed? And that's something I'm going to put to these guys just to see how they handle that questioning. But, from the PFO standpoint, the way I treat it is, from a cardiologist standpoint is, yes, we'll talk about the PFO, the risk factors, and if we've determined as a team to close it, we'll close it. And I can go through the specifics of the procedure shortly in a while. But the other thing is really a long conversation about secondary risk factor. To me, if a patient comes in with really uncontrolled diabetes and they've got this hole in their heart, I'm spending a long time telling that patient, we need to do what it takes to get your diabetes under control and really your cholesterol under control and maybe reduce your risk from there. Then maybe let's talk about this PFO, unless it's just an obvious PFO. So I think a really responsible, holistic approach as a cardiologist to secondary prevention is important. But then there's the discussion, just if you ask me a little later, then we'll talk about the procedure itself.
So we'll talk about how do we come to make a decision to actually close the PFO. But as part of the background, we have really two devices, to close the PFO. And there had to be almost a dozen trials. I mean, I used to go to meetings in 1980s and 1990s, to Europe, and the people were closing, PFOs right and left. And until 2006, when there was about over 4,000, PFO closures going on every year, just in the U.S. And that's when they decided to do a clinical trial. There had never been a clinical trial, and it took 10 years, until there was a PFO device actually that met the FDA requirement. So why did it take so long? What is that device? And what did these clinical trials really tell us about whether that's a good option or not?
I'm going to talk about the device just very quickly. I'll get that bit off the table. Then I'm going to kind of hand over the question about the trials. But the device is a very small mesh. It's extraordinarily light. If you were to put your hand out and close your eyes, it's almost so light that if you were wearing gloves and you couldn't feel it, you probably wouldn't even know which hand would put the device in. I mean, it's like a feather. And it's like a clamshell. That's the best way to describe it. So we go through the hole in the heart, one disc will open, and then you come to the other side of the heart, another disc's open. And there's like this elastic energy which brings it together and closes it like a clamshell. And so the device itself, the device that's now been approved, honestly, is very, very similar to the devices that were used before. We now have a dedicated PFO closure device, 2 of them, with different companies. There's maybe tiny advantages to one or the other one in different circumstances, but honestly, both are equal and not worth even discussing which one's better or which one's not. Really, it's what's the operator comfortable with, what can you do safely and well. And then there are a number of new trials underway with newer devices, such as suture-based stitch devices, kind of patch devices and other, but really with the complication rates that we're seeing currently being so low, it's going to be hard to beat the current device, but there is a dedicated PFO closure devices now.
So Mustafa, obviously there are other people with holes in their heart. For example, some patients with atrial septal defect or patients with ventricular septal defect. And is this kind of the same device, but just kind of a different size, or is there any difference?
I think really important point, because I haven't, I guess, really made it clear. The hole we're talking about is in the top chamber of the heart. And the hole we're talking about is more like a tunnel. And so for years, we have had holes which are just large holes in the top of the heart. They're not tunnels, they're just holes, called septal defects. And those had their own dedicated closure devices that are different. The role of those closure devices is actually to, in the middle of the device, it's to take up the space that the hole is taking, right? Now, in the PFO closure device, it's not to do that. It's really just to bring the one side and the other side together so they meet in the middle. It's not trying to fill in the whole of a device. So a PFO closure device is very different than a ventricular septal closure device or a atrial septal closure device, in that you're not trying to occlude the hole with the tissue in the middle. You're actually just trying to bring two kind of tissues together, and really just by the nature of that, it will occlude the hole.
Very important, distinction here. And just to mention briefly, these clinical trials that finally led the FDA to say, okay, this is maybe superior to medical therapy for a certain patient. And I guess I'm thinking mostly of the RESPECT trial, and particularly the long follow-up. Why did it take so long, to be actually to show the benefit?
Well, in every aspect of medicine, I think well-conducted trials with appropriate patient selection, are the game changers. I think sort of the PFO trials, we kind of divide in sort of the older trials, older meaning, starting in 2012, and have in mind 3 main trials that came out, Closure, PC, and the early part of the RESPECT trial. And the problem, all of these PFO trials, older ones or newer ones, enrolled relatively similar subset of patients, younger, less than 60, ones with a stroke. The problem with the older trials, I think, leading to a non-significant results were lack of appropriate patient selection. Patients were not appropriately selected to have truly cryptogenic strokes. Some of the trials enrolled patients with TIAs, transient ischemic attacks, and there's a whole set of problems sort of lumping TIAs with a stroke. And devices were different. Closure trial used a little bit older device, which is not in clinical practice anymore because it had different complication rates and et cetera. And most importantly, did not really focus on appropriate PFO selection. Every PFO, whether small or large or associated with atrial septal aneurysm, were lumped in the trial. So that overall led that each trial was negative on its own, did not find significant benefit of PFO closure in addition to antiplatelet therapy. However, when I think it was early 2016, when the data from the RESPECT trial and the PC trial got analyzed together, there was a trend towards benefit of closure as opposed to medical therapy. So that led then to development of the other new clinical trial. First of all, the long-term follow-up of the RESPECT trial, as you mentioned, and then two additional clinical trial, close and reduce. And what close and reduce did really was really focused on a really specific cherry picking of those patients who would benefit from PFO closure, focusing on truly cryptogenic ESUS patients and truly selecting the high risk PFOs. One trial enrolled only patients with large PFOs, and another one only enrolled patients who had either large shunts or atrial septal aneurysm. So in truly cherry-picked selected patients, we did find that PFO closure is beneficial. So, after there are several meta analyses afterwards that sort of have the data from the last three trials, long-term follow-up of the RESPECT, close and reduce, and the earlier two positive to the trials. And overall, these days, from the new evidence, we know that the PFO closure is superior to antiplatelet therapy alone in highly selected cherry-picked patients who had stroke for secondary stroke prevention. There are several questions. One important thing I guess I should mention is that we are really talking about highly selected patient population, and that's the key to emphasize. The PFO closure is not beneficial for everyone who had a stroke and has a PFO. Patients need to be highly selected, really truly less than 60 years of age, lack of traditional risk factors, and non-smokers, and with a high risk PFO features. And even all this included in this highly selected patient population, the benefit of the closure is quite modest. With all the numbers from the meta-analysis, absolute risk reduction of 0.6% per year, it translates into number needed to treat of 30 in 5 years to prevent one stroke. And I sort of wanted to sink in that a little bit. We need to close 30 PFOs in 5 years to prevent one stroke, and that is what we are trying for the heart-brain team to really emphasize and relate to the rest of the medical colleagues that yes, PFO closure is beneficial in selected patients, but you have to understand that it's really in selected patient population and the benefit is modest. There are also complications, but we are very fortunate that patients at UAB have very, very low risk of complications, given that, Dr. Ahmed and his group are highly skilled. We can talk about complications, but, the main thing that we discuss with the patients about complications is really the risk of atrial fibrillation. And then, as time allows, we can talk about that in detail.
Thanks, Akam. And we'll talk about that in a little bit when we talk about a specific for a patient. Sue, in your practice, let's say you have like this young woman, she's had a stroke already, and she's just like 35. And if you kind of hear that something is superior to medical therapy, I mean, wouldn't you want to close that PFO? What do you find in clinical practice? I mean, it seems like if I was that patient, I would try to do everything I can not to have another stroke.
Mm-hmm. And that is our shared goal. Really, the main goal of my practice is to prevent patients from having another stroke. And so, but also I would be a bad doctor if I recommended doing something that's not going to be helpful for the patient. And so that's why we select patients so carefully, because as the older trials showed, if we just take any stroke patient and with a PFO and close them, we find there is no benefit really. It's the highly selected patients who are going to benefit from this. And so my personal approach when I see a patient with a cryptogenic stroke who has a PFO, I look at three main factors. I look at the patient factor, I look at the stroke factor, and the PFO factor. So the patient, I look at how old is the patient and what kind of risk factors does the patient have, including do they have any risk for forming thrombosis, either in their vein or in their artery? Are they at high risk of forming a clot? And do they have any other indication for blood thinning medications? Do they need to be on a blood thinner for some other reason, a strong blood thinner for some other reason, which may negate the need for PFO closure? So that's the patient factor that I look at. And then I look at the stroke factor. Was it truly an embolic stroke? Are there multifocal strokes? Or on the MRI, is there evidence of a prior, perhaps silent stroke that could have happened without the patient realizing? And like Dr. Bakradze mentioned, is this a TIA or a true stroke? That's also goes into the consideration as well. And then I look at the PFO factor. Is there a large shunt? Is there atrial septal aneurysm going on? Is this a high-risk PFO, or is this a tiny little thing that's, been there all along and not going to cause any problems? And putting all of that together, I make a final determination. So it's very not clear cut. It's never black and white. There's a lot of gray in between, but we do have to take in all factors before we come to the right conclusion. And usually when I explain the steps involved and why I think a patient may benefit or may not benefit from PFO closure, the patients usually agree with me and understand the decision-making process.
So I'm going to jump in here. I'm particularly pleased because I just learned for the first time how to use the raise hand feature on this thing. So there you go. That's a goal of mine.
You'll have to teach us how you do that, Mustafa.
I'm trying to figure out right now how to remove the raise hand, but there you go. So, you just talked about, and I get this question a lot. So someone comes in with a TIA and they're like, of all the things, when I have a cardiac procedure, if I'm doing a cardiac procedure on someone, I will tell you, I am much more scared of a stroke than I am of a cardiac complication. Because we know how to handle cardiac complications. We pretty much know how to take care of them. And most of the time, everything's going to be okay. Whereas when you have a stroke, it's life-changing from that minute often for people. And so as you imagine, TIAs are just exceptionally scary for patients. And I have many patients come in every single week that have had a apparent TIA. And then I'm sitting there and they're looking at me like, how can you not close this hole? Why are we complicating this? Just close it, because you've just told me how easy it is to close. And I'm like, nope, you got to go through this heart-brain pathway and this, that, and the other. So, and I say this having sent patients to you guys where patients have ended up having, multiple sclerosis, or ended up having some other degenerative disease, or ended up having. So what do I say, or what do you say to a patient that's had a TIA when you're saying, no, that's not a stroke. It's not the same thing. But by the way, that's a risk factor for having a stroke. Don't worry about it. Because to me, it seems exceptionally scary. What's the workup of differentiating a TIA and a stroke? And what's the role of that differentiation in PFO approach?
Yeah, that is an excellent question. And I think I'm even so happy that you've been asking this question and not lumping this with the stroke. So the big question that we need to answer, is this a true TIA or not? And we see, Dr. Kwon and myself, that a lot of things in clinical practice are called TIA. Patients had, 10 minutes of just transient dizziness or lightheadedness. It's called TIA. And, there's arm tingling for 15 minutes is also called TIA. And the difficulty with diagnosing TIA is that there's really no, diagnostic test that really tells you that you had a TIA. It's really based on clinical symptoms and negative MRI. So the definition of TIA changed in 2001, but for some reason, we still kind of think that if you had a resolution of symptoms, we can easily call this a TIA. And that's really not correct. Before, we would say if you had a stroke-like symptoms that resolved within 24 hours, you can technically call this a TIA. That definition has changed and requires now not only the resolution of symptoms within 24 hours, but also negative MRI, meaning that you do not see an acute ischemic stroke correlating with your TIA symptoms, in addition to the resolution of symptoms. So every patient, if you're truly calling this TIA, should have a true localizable neurological deficit and should have had a full stroke workup, including MRI, and had negative MRI. And that is really rare to see. Unfortunately, patients with TIAs do not seek medical attention often enough to have a stroke workup. And these TIAs get diagnosed later on outpatient basis, sometimes years from their symptoms. And a patient mentioned something I had 2 years ago, 10 minutes of dizziness, and that is, called TIA in their clinical chart from that time on. So the first thing, again, determining was there a true TIA or not. And then the second is, how can you prove that TIA is embolic, right? It's the symptoms oftentimes are so nonspecific, and very, very rarely you can have a clear embolic symptom, meaning that the stroke-like symptom that you can say, well, this symptom was really localizable to this area of the brain, so the ischemia must have been truly embolic in etiology. And that is really rare to prove. So because of that, to not really mess up with the data of the trial, most of the trials have excluded patients with TIAs, especially new PFO clinical trials. So we really do not have evidence of closing PFO in patients with TIAs. I think you have a good point that there are probably subset of patients who truly had embolic TIA, meaning that there is a ischemia in the areas of the brain that could very well been from the paradoxical embolus in relation to PFO. But we have no way of proving and no way of knowing that the PFO closure will be beneficial in them. So given lack of data, we generally do not recommend PFO closure.
And I'd like to add that a lot of TIAs end up not being due to a vascular phenomena. TIA is oftentimes it's a basket term for any transient neurologic symptom. But if you talk to a stroke expert, I think in a lot of cases we would be able to determine whether this was a true TIA or something that was labeled as a TIA but was not actually a TIA. So, we can oftentimes make that distinction just from really taking a detailed history. And so that's why we get involved.
So maybe you could explain to me a little more about how does the heart team, what are the dynamics, and how does the heart team actually makes all these decisions? Do you, is it like the structural, the heart team approach where everybody sits in the room and discuss, a particular clinical scenario with the neurologist reviewing the MRI, and you have like Dr. Ahmed or some of his colleagues reviewing the echo and kind of decide, whether a patient is a candidate or not?
As a policy for our structural heart team, and this is really a testament to working with these guys, it's a mandate, like we will not close a PFO without a team approach. Like it simply won't happen. So from my standpoint, getting many of the referrals come in for closure to structural heart. So there's two sources of referral that come in. One is actually from the neurologists, and that's being in hospital, had a stroke, had the workup, and then there's a message that goes off and says, hey, we've done this bit. Can you now look at the cardiac standpoint? And if you agree from a cardiac standpoint that this is appropriate, please go ahead and close the PFO. So those are the ones I feel like they're the ones where everything's done and you've got that bit of the workup. The next bit comes from an outside primary care doctor, comes from an outside neurologist maybe, comes from an outside cardiologist and says, can you close this PFO? The immediate what happens is I will have a conversation with the patient and be the first point of contact. But within the first few sentences will be, this is how it is. This is a heart-brain approach. You know, we're going to arrange consultation with our stroke colleagues, neurology, and we have leveraged at UAB. We've leveraged virtual technology for that as well, partly through the use of Vital Engine to bring in referrals, send images, share images, bring these things in, and also with Vital Engine, kind of using and these guys will probably say the same. A lot of this can be done, some in person, but a lot through telehealth also. And that's been revolutionary, really, something we have as a team to write about or are actively participating in our own research projects on this. But really it means now, because many of these patients are from 3, 4, 5, 6, 7, 8 hours away. So yes, we're going to make the initial trip and we may do some testing and we may do a T, but really, and you guys let me know, but it seems like from just the way the communication's done, a lot of this can be done in a virtual multidisciplinary collaboration, which really makes it easier for everyone. But it is a mandate at UAB that all patients undergoing PFO closure for cryptogenic stroke from our heart team standpoint will not be done without that. And it's not always, hey, close it. Sometimes, very, very occasionally, it's well, you know, if you feel strongly to close it and this, and we'd understand the patient saying this, and it's not unreasonable. You know, just like the slight U for uncertain. But most of the time, it's a very collegial thing. And what's amazing here is the conversations 10 years ago were neurologists sitting over here saying cardiologists just don't know what they're doing. They're trying to close every hole in the heart and a bunch of cowboys. And the cardiologists over here saying, we can close that. And like, why are you not telling us to close this thing and it can be done? And why are we like getting caught? Now it's totally different. Now it's like, I like to think this collaboration, which I think will be the future, you know, and I think we're ahead of the curve on this, will be the future, will be everyone's on the same page, just trying to do the same thing, the right thing. Have you guys been using telehealth mainly for this? And when you do, so are you like bringing all the, like, what is it that, just for that tele-collaborative aspect, what imaging and this, what is it you exactly want to see before you see them? And also another question I've always wanted to ask, how do you guys do, like neuro is just famous for like having the world's best physical exam. How do you do this on tele?
Yeah, so you can definitely have your tricks. Tell us your tricks how to do neuro exam. But in terms of the workup, as you said, most of the patients that come through the cardiology, through your team to us for the referral have imaging done. And things like MRI of the brain, blood vessel pictures, whether it's MRI angiogram or a CT angiogram, and when you have cardiac imaging, echo, the rhythm monitoring. A lot of times, maybe some of the blood work, like hypercoagulable panel, is lacking. So Sue and I ensure that the stroke workup is complete. And as you said, I think given COVID, most of the initial evaluation, I think, has been through the telehealth. So we would review images in advance and decide what is lacking to complete the stroke evaluation, and then I have patients complete. As you mentioned, patients, live, several hours away, and we could do a lot of workup locally. They don't have to all come at UAB. So once we have the complete stroke workup, and then we discuss it with you, and then we decide whether this PFO closure is appropriate or not. In terms of neuro exam, it's quite challenging to do that through the telehealth, but we've come, my favorite trick of all in doing tele-neuro exam has been something called, instead of the finger nose exam, which is, I'm sure all of you know, I've been doing something called a nose camera exam, where I would have patients touch their nose, touch the camera, and it's pretty precise in terms of looking at the ataxia. So this has been my favorite trick to learn during televisits, but I don't know what Dr. Kwon has.
Yeah, and I think telehealth has been a game changer because, yes, we can save patients a lot of time. They don't have to travel 3, 4, 5 hours to come here. And You mentioned the physical exam part. The physical exam and the neurologic exam is very, very important in the acute phase of the stroke in the hospital, in the emergency room. It becomes a little bit less critical in the clinic setting. And in the clinic setting, the counseling part and the education part becomes much more important. And with telehealth, we're able to have like caregivers and family members near the patient, with the patient, to hear the counseling part. Whereas, nowadays with COVID, we're only allowed to have one caregiver come with the patient. And sometimes the patient has to come alone, and patients with stroke, they may not have, a full ability to understand the nuances of all of the decision making. So it has been very helpful to reach them in their comfortable environment to provide this counseling and education.
Dr. Bouchard, I'd like to comment on one thing, and get these guys' take on it. So patients often come in, and a question I get is, well, I saw a neurologist and they said this, and I saw a cardiologist and they said this, and now I'm coming to you and you're saying this, and now you're sending me to another neurologist. Why should I trust any of you? And what's interesting, my answer to them, and you tell me how, my answer to them is, you may have a wonderful neurologist that's very well trained in that local environment, doing a great job, and you may have a great cardiologist over there, but I think the chance of them talking in a fashion like this, where you're all patient-centered, multidisciplinary approach, is almost zero, because this is an innovative and hard thing to do, even in an academic setting. Never mind in a setting where workflow go in. You know how it is. People see people at different times of day, and so I often tell them that, and then I also tell them, well, you're going to see people. We deal with this. We deal with this in a volume that I don't think many people deal with. What is the relationship? In just say there's people listening to this who want to set up programs, and look at this. What is the relationship, or I should use the word politics, of the neurology community in this? Like, as the outside neurologist being like, why is anyone looking at this again? And why are these neurologists doing this? Or are they just like, great, we're happy for you to look at it? Or are you just not in contact with those people? How does that work?
I think neurology is a pretty broad area, and stroke neurology or vascular neurology is a pretty specific area within neurology. And dealing with PFOs and directly being able to communicate with the actual cardiologists who close PFOs, that would be a really small proportion of neurologists. So I think there is a true benefit in seeing a specific stroke neurologist who is part of the heart brain clinic.
Yeah, I agree completely with Sue that it's important to be really evaluated by specialists who deals with that on daily basis and is most up to date with the current literature to really come up with the best strategy for secondary stroke prevention. So, we don't often know whether patients saw a movement disorder specialist or a cognitive neurologist as an outpatient, or a general neurologist who, may not be dealing with this on daily basis. So their thought process about the benefit of PFO closure might be very different to what we do at UAB. And truly, we're a large stroke center. We have now, I think, 7 or 8 stroke neurologists, and Dr. Kwon and myself are the predominant ones who do, work in heart brain clinics. So even a lot of times our colleagues who, do stroke and only stroke on their daily basis would still ensure that the patients who are undergoing PFO closure would come through us, and, discuss with us before recommending PFO closure. So it is something that you need to be doing often, and in order to be most up to date and to provide best advice for patient regarding closure.
Well, so I'm this young patient now. I'm this 50-year-old guy. I've had 2 strokes, and the heart brain team has met, and really they concur that I would really benefit from a PFO closure. So. My appointment is tomorrow. Mustafa, can you walk me through, like if I'm that patient, what's going to happen to me? I'm coming in tomorrow morning.
Yes. So first I'll start by telling patients this is a percutaneous procedure. And there's still many patients that come in and think we're going to do some kind of big open heart surgery to close that hole. And what I tell them is actually this is going to go through a relatively small to tiny hole through a blood vessel in the groin. And it's the kind of procedure where we now, and we have a large series of this, we send all our patients home the same day. So it's the kind of procedure where you'll come in, you'll have your procedure. We expect you sitting up 2 hours after the procedure, walking around an hour after that, and going home a few hours after that. And so that really sets the expectation of an outpatient, comfortable procedure. The procedure itself is comfortable. Anesthetic would be used in the leg. And in our cases, we use cardiovascular anesthesia in all of our cardiac cases. So in terms of comfort and comfortability, you will not feel you will not feel everything from the first tiny needle stick to afterwards. It's a very comfortable and should be a painless procedure. Now, there's two ways to do this procedure. One is to use a TEE probe, which is a probe, which a camera which goes down the throat towards the heart. The difference when we're doing that is we do put our patient to sleep, even if it's just for 10 or 20 minutes, really to allow comfortable use of the TEE probe and make sure the patient really doesn't feel it. We will wake the patient immediately up afterwards on the table. There is some advantages to TEE. The reason I use TEE a lot in my practice is it doesn't matter how complex the anatomy is, we're going to close it. So even if it's the most complex or the quickest, it's just the most efficient, straightforward way to do a procedure which I believe is the lowest risk of complication if done well. There's another technique we use where we go through the leg with a small camera called an ICE catheter, and we put that up. And really the point of these cameras is to demonstrate you're across the hole and the device looks good at the end without complication. And then the procedure itself, honestly lasts, the quickest one is just a number of minutes. And then most should be done within 10 to 15 minutes on the table. And after that, we wake you up and kind of go on with the procedure afterwards. And so hopefully that shows it's an outpatient procedure. It's a comfortable procedure. There's no large incisions or anything like that. And then in terms of after the procedure, you might take it easy in terms of heavy lifting for a day, but 2-3 days afterwards, you go and do what you want. I mean, you're back to getting on with your normal life.
What about medication after the procedure?
Yes. So aspirin is uniformly taken basically by all these patients. And by the nature of being there in the first place and having gone through the workup and having that, you're on probably an aspirin. You're on may well be a cholesterol type medication, if that's indicated, which, these guys can kind of comment more, but I think that's pretty much most patients. And for this device itself, what we like to wait for is a number of months, often a 6-month period, where a coating on the outside of the device develops. So your body kind of does a process called endothelialization, where it basically welcomes this thing in, grows a covering over it, and says, we are compatible. And the beauty of that is, once that process is done, the need for a lot of blood thinning medication afterwards, just for the device itself, goes down. Now, why use blood thinning medication with a device? Because initially when we put the device in, we don't want, before that endothelialization process, we don't want any tiny, tiny clots or anything forming on there. And so that's one reason. The other reason is the trials that have looked at this have looked at it in the setting of using those blood thinners together, often for a period of 6 months or so afterwards. And that's typically something called Plavix that will be used. And it's another blood thinner. It's almost like taking another aspirin. And there are rare circumstances where someone can't take aspirin, so we'll use Plavix. Or someone can't take, Plavix, we may use a large aspirin and just discuss with the patient what we're doing and why. But typically it's called DAPT, dual antiplatelet therapy, for that prescribed period of time. And then after a while, you'll come off that. I'll defer to doctors, Bakradze and Kwon. In general, in a stroke, how long will someone be on aspirin and Plavix for? That I don't know, but hopefully that answers most of the procedural question.
So, Sue, do you want to help us with this? I mean, this patient just had a second stroke. Now he's getting his PFO closure. You keep the aspirin and Plavix for 6 months or for a year?
So in stroke prevention, there were clinical trials looking at dual antiplatelet therapy versus one antiplatelet therapy, and there's no benefit. What that means is the risk of complication with using long-term dual antiplatelet therapy outweighed any benefit that it provided. So after that 6-month period that's necessary after PFO closure, we would probably drop one of those 2 antiplatelet agents and continue on with usually most commonly aspirin.
What's the role of the statin in the secondary prevention of an embolic stroke?
In most patients, or overall stroke patients, statins were shown to be beneficial in reducing the risk of a future stroke. Now, it's especially more pronounced in people who have atherosclerotic disease or plaques in their vessels. But sort of all comers, they looked at people on statin versus not on statin and found that people on statins had a lower risk of a future stroke. So we do generally recommend statins for patients who have had a stroke. But there are exceptions, like women of childbearing age. We don't want to be using a statin if there is any chance of pregnancy. And if this is truly, just attributable to a PFO, then we may stop the statin if they don't have a pathologically high cholesterol level to begin with.
We talked about the complications that were very, very rare. Certainly, cardiac perforation or displacement of the device, is almost, thank God, non-existent. But we mentioned a little bit about in some of the trials, AFib that seems to be detected afterward. Was this kind of AFib related to the device, or maybe AFib that we missed, that was there but not really discovered? I mean, what do you think?
Yes, of course. Yeah. So one of the significant risks, I would say, after PFO closure could be development of irregular rhythm called atrial fibrillation or atrial flutter. The clinical trials have reported different numbers and different percentages of incidence. I think the highest incidence was really 6.6% of AFib after PFO closure. But most of the AFib that was found after the procedure was transient and resolved within 2 months. So, it could be related to the device itself. There's not a clear known reason why AFib develops after PFO closure. As you mentioned, the one theory is that there's an irritation of the cardiac structure with the device placement. So certainly could be device related. But I think you also brought up important question that could this be that patients, these stroke patients already had occult AFib, and we were just not able to detect AFib with the first 30-day of monitoring before PFO closure, and then now AFib is showing. Which obviously we not be able to answer. We know that longer you monitor for AFib, more likely you'll be able to find it. So certainly small subset of patients might have had AFib before their index stroke. It's again, most of the AFib is transient, but it's still very important to approach newly diagnosed AFib as we usually do in known PFO closure patients. So we do monitor patients after PFO closure some time for the atrial fibrillation. It really varies. And I should mention, there is really no guidance on how long should we monitor patients after PFO closure for AFib. And so it's really based on the treating clinician.
One other thing in terms of complication. So the chance of complication is small. I would recommend this procedure done by structural heart specialists or people with a long-standing specialist interest and track record. PFO, again, any procedure for anything, it's not about, hey, can I do the straightforward procedure that goes well? It's can you do the more challenging procedure if this were to become that? And could you manage or foresee complications that are happening? And in that setting, like you said, device embolizations, which means the device coming out and jumping out through the heart chamber going to the aorta. I mean, I've seen and heard of everything and anything happening in that situation, but it's less and less and less, which it should be. The groin area where you go in, it can always be slightly local vascular complications, but with the use of more refined techniques, that's less too. And importantly, the vascular complications and the cardiac complications being mentioned in the trials that have looked at this, the larger trials, there was no associated long-term morbidity with those vascular or cardiac complications. So we're definitely not handing off a long-term procedural related complication But again, this is what I tell everyone that looks at a trial: do remember that the people that did those trials, that ran those trials, did the procedures in those trials, the neurologists that looked at those trials, these are not your average, wide specialty all-comer. These are people with specialist interest in these fields that really have expertise, which comes through a kind of defined approach of just dealing with that over time.
What about if you have a residual shunt? I mean, do you see that sometimes? And how frequently does that happen? And, is there still a risk of having a third stroke despite the PFO closed?
So I'm gonna start on this one and no doubt be corrected shortly by these guys. So the way I've understood and seen this is the closure is the closure. And independent of a bubble or two or whatever that is going through afterwards, the risk for that patient is dependent on successful device placement. So, now having said that, we do bubble studies on patients after every single procedure. We do them in the 1 month follow-up and the 1 year follow-up. And we're pretty obsessive about trying to answer if in the very rare circumstance there was some shunt there, why it's there. But my current understanding is as long as you've occluded most of the tunnel, done the closure, appropriately placed device, I'm not sure there's a large association between a tiny bit of residual shunting. And I'd be interested to see what these guys say, because I'll be asked this by patients that have had closures elsewhere as well. They'll say, well, we've got a bubble study and it's positive. Do you need to go back in? And my answer is usually no, I'm not going to go back in and do anything. But I mean, what do you guys think about that?
Actually, one of the clinical trials reported the rate of complete closure of the PFO. And I think it was something like 72 or 73%. And I thought, oh, hey, that's lower than what I expected. But I think they also mentioned that the clinically relevant complete closure was something like over 90%. And with those, with that percentage of incomplete closures, still the net outcome was that there was a benefit in these select patients. So I think in the large clinical message is that once you have a successful PFO closure done without any obvious complications, then the effect should hold.
Right. The only large residual shunts are associated with recurrent stroke. So, and these are really rare. So most of the, tiny, small shunts after the closure do not have clinical significance. So, net benefit is usually good.
It seems like over the last 20 years, we've seen a lot of development of these techniques that really kind of have created better results and better outcome for the patient. Let's talk a little bit about the future as a way to finish. I mean, I'm seeing a device now that is placed in a young patient, and I'm thinking maybe in 20, 30 years or more, they're going to develop AFib, and the electrophysiologist is going to be very upset with us because now there's this device, which, he used that little channel to do his AFib ablation. Is there actually newer device that are being developed that will go away eventually? Or?
A couple of comments on that. So firstly, what you'll find is when we compare to years ago, I would think everyone's going to be much happier now because much less people are getting closed than 10, 15 years ago, just because it's refined. So really only the people that need it. Secondly, with the training and flourishing of structural heart specialists, when I go and do a procedure, yes, for 1 second, I might think, I wish that device wasn't there. I really wish I could have gone through there. But really, it's like, okay, I'll just work around it. And I know many electrophysiologists who feel the same. We won't worry about the closure device because we need to do something else. We'll just work around it. And I've had cases where I've had to go through it before a closure device and an ASD device. And once it's endothelialized, as time goes on, it's amazing. Technology develops that makes that question seem like insignificant later. The other thing is the device is a lower profile. So one thing you asked earlier is about the PFO device. How does that differ from the old, what we used to call the clamshell or cribiform device? Really, one of the discs on one side, and then the other disc are a bit smaller. And so I find over time there's lower profile devices. And in terms of the future, there are ongoing trials of suture-based devices. So you basically go through this tunnel, you kind of click in, and it puts a suture in there, and there's nothing. It's deviceless closure. Now, I really do want to see long-term data of that before I even think about starting to routinely use that in practice, because then what you want to see shunt closure, and to my way of thinking, they should have to undergo the same rigorous kind of evaluation that the other stuff has. But yes, structural heart and its devices, I would not be surprised if we were sitting here in 10 years' time, you go up with something, you freeze something together, or you push something together and it's just gone. I mean, it's been mind-blowing how fast this field is moving of all structural stuff.
Eka, where do you think we're headed with the PFO closure device and cryptogenic stroke?
Yeah, I think certainly refining the devices would be important, as Dr. Ahmed was talking about, and maybe even the era will come that we need to avoid, and it will be, as he said, deviceless PFO closure. But I think what I would like to see as a non-proceduralist, as a clinician, a non-proceduralist is there are many clinical questions that are unanswered in PFO closure. And I would like to see more data on that. Perhaps patients who are not suitable for PFO closure. You determine they might benefit from PFO closure, but for one reason or the other, they're not suitable for it. Is antiplatelet therapy better than anticoagulation therapy? I would like to see that, because there's some trend that the more stronger blood thinners like anticoagulants might be better. Duration of antiplatelet therapy after PFO closure, is 1, 3, 6 months better. PFO closure in patients who are over 60 years of age. I mean, most of the trials, as we said, enrolled patients who are less than 60, but, how do you distinguish 59-year-old patient from 63 who is otherwise really healthy, non-smoker, does not have traditional risk factors, and you think the stroke is associated with PFO? I mean, would you say just because the patient is not less than 60, closure is not indicated? So I'd like to see the data for people over 60, and then other duration of cardiac monitoring after PFO closure, and how long should we monitor these patients and look for AFib and et cetera. So there's still many clinical questions to be answered, and I think it'll be fun to see what the data will hold, and alongside of developing new devices, of course.
Sue, it seems like in cryptogenic strokes, only 40 to 50% have PFO. What about all the others? What do we do for these patients? I mean, they had their second strokes already.
Yeah, really very important is looking for occult AFib. And sometimes it does require a really, really long period of monitoring to find that. There's also a study called Arcadia looking at atrial cardiopathy without AFib. So they may have some underlying cardiac condition that predisposes them to forming clots in the heart that embolizes to the brain. But AFib is just part of that. And they don't necessarily have to have AFib to have a cardioembolic stroke. So, looking at their blood, looking at any unidentified risk factors. Nowadays, we're finding more things like homocysteine or lipoprotein A, factors that we didn't know before that could lead to a higher risk of stroke. So there's lots of things that we look for and we need to find out more about.
That's interesting. I do think crowdsourcing as you go forward, there's like 5,000 different watches now that can tell you if you have atrial fibrillation. And at some point, people are going to leverage this and say, okay, everyone that's had a stroke, like we're going to look at your thingy watch for the next, 10 years. And these questions, it's great, right? These are much easily answered. The one thing I've not understood about stroke is, when someone has a heart attack, we have this blood test, right? Troponin. When we go in, how come there's not a troponin for TIAs? Like there must be something like that in the brain, right? Where you can figure out which TIA was embolic. Or is the MRI just so sensitive no one cares about that? Or is something like that being developed?
Yeah, there are actually, we say the neurologists are 20 years behind of cardiologists. So we apologize for that. But there are studies actually developing that are looking into different biomarkers. There are, studies looking at the microRNAs as a biomarker. So even not only, answering, yes, there is a stroke, no, there is no stroke, but also looking at the stroke etiologies and then other different biomarkers. So I think in the next maybe a decade or so, we'll have more data identifying stroke and stroke etiology based on the biomarker and not, waiting for the MRI itself to happen.
I do want to say that we may be 20 years behind cardiologists, but the brain is more nuanced than the heart. You mean you
can't replace it with a pump? Yeah, I felt guilty when she said that. I was like, I'm just going to stay completely silent here.
So looking for biomarker, we're actively, there's active clinical trials and research studies going on to look for a biomarker, but it has not been easy because of, the complicated nature of the brain and the different components inside of the brain.
Well, I think that Mustafa is very fortunate to work with an incredible team. It makes really the heart-brain team really shine. And appreciate so much the help of Soo-Young Kwon, as well as Ekaterina Bakradze, incredible neurologist, stroke neurologist, at the University of Alabama, and you make a very strong team. And I hope that you learned a lot on this cryptogenic stroke and PFO-related stroke, to close or not to close, and the role of the heart-brain team. Well, you saw it right there. Thank you, folks.
Thank you for having me.
Thank you for having us.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.